Boa noite a todos. Então, vamos conversar um pouquinho a respeito de SOP, né? Então, vamos lá. A SOP tem um novo nome. Síndrome Ovariana Metabólica Poliendócrina. E para a gente celebrar, né, essa mudança do nome da SOP para SOMP, a Sogimig trouxe para você uma sessão online com o coautor do artigo histórico e alguns especialistas. A sessão tem como objetivo apoiar profissionais de saúde na compreensão dessa mudança e na melhoria do cuidado multiprofissional às pacientes. Então, eu tenho uma imensa satisfação de apresentar a vocês o professor Michael Costello, com quem eu tive a honra de conviver na University of New South Wales durante o meu pós-doutorado na Austrália. Thank you, Michael, for being here with us. And thank you for your willingness to join us during Fertility Awareness Month, organized by our Reproductive Planning Committee from Minas Gerais Society of Obstetrics and Gynecology, Brazil. It's great to have you here. So, PMOS, formerly known as PCOS, is a multi-system condition that affects various hormones, especially androgens and insulin, and it is the most common hormonal condition among adult women, affecting about 12% of them. It can cause a variety of symptoms, including menstrual irregularity, acne, excess hair, a higher risk of anxiety and depression. In addition to being the leading cause of infertility related to reduced ovulation. So Dr. Costello will be presenting a talk based on his recent widely known publication on PMOS. Dr. Michael Costello is a gynecologist and board-certified specialist in reproductive endocrinology and infertility. He serves as medical director of Monash IVF New South Wales, and is a clinical academic at the University of New South Wales, UNSW, and the Royal Hospital for Women in Sydney. An internationally recognized expert in reproductive medicine, he has published more than 100 scientific papers and book chapters, and has played a leading role in developing major evidence-based guidelines on PCOS and unexplained infertility, including the International PCOS Guidelines 2018 and 2023, and the ASHRA Unexplained Infertility Guideline on 2023. Dr. Costello is a member of the International PCOS Name Changing Steering Committee and was a co-author of the landmark 2026 Lancet paper introducing the new terminology polyendocrine metabolic ovarian syndrome, now known as PMOS. So thank you, Michael. The screen is yours whenever you're ready.
All right, so thank you very much, Nara, for the kind invitation to present as part of your lecture series in Brazil. I'm honoured and excited to do so. I'm here from Sydney, Australia. I wish I could say it was sunny Sydney, Australia, but unfortunately today is raining. But the title of my talk today is PMOS, the new nomenclature and its impact on multidisciplinary care of the syndrome. So background, and Nara alluded to some of this in the introduction, is PMOS, or polyendocrine metabolic ovarian syndrome, formerly known as PCOS, is the most common endocrinopathy in reproductive age women. It has a global prevalence of around 12%, or 1 in 8 adult women, and affects more than 170 million women worldwide. And it has broad clinical features. So it's a chronic multi-system condition, including reproductive, psychological, dermatological, endocrine, and cardiometabolic features. For example, reproductive features can include the irregular cycles, infertility, pregnancy complications, endometrial cancer. Psychological features can include mental health issues such as anxiety, depression, suicide, poor quality of life, eating disorders. Dermatological is skin issues such as acne, alopecia, and hirsutism. Endocrine being hormonal issues such as insulin resistance, hyperinsulinemia, hyperandrogenism, central neurocrine abnormalities, higher body weight, and type 2 diabetes. and cardiometabolic being hypertension, dyslipidemia, sleep apnea, and cardiovascular disease. So how do we diagnose polycystic ovary syndrome? So it's important to note that with the new name change, the diagnosis is unchanged. And it's the International Guideline Diagnostic Criteria 2023. I would think that many of you in the audience today are aware of the International Evidence-Based Guidelines on PCOS published in 2023, of which I'm an author, and there were 5 guideline development groups assessing all different aspects of PCOS, and I was the chair for the infertility section of these guidelines. These, or a summary of these guidelines, so a much shorter version, was also co-published in these 4 major international journals, just to have outreach and improve translation to the world. So what are the international guideline diagnostic criteria? Well, in adults, it's the Rotterdam 2003 criteria. Now, a lot of people are still referring to how do you diagnose PCOS? Well, it's the Rotterdam criteria. Well, it's not, okay? It changed, and it changed in these guidelines in 2023 to include the Rotterdam criteria, but we've also added raised AMH level, all right? And for adults, you need 2 out of the 3 criteria, which are listed there below, being oligoenovulation or enovulation, clinical and or biochemical hyperandrogenism, polycystic ovaries or elevated AMH levels. But of course, you've got to exclude other causes for those features. But we also introduced a diagnostic criteria for adolescents as well. So that's the other thing that's different to the Rotterdam criteria. And for the adolescents, you need 2 out of the first 2 criteria, being oligoenovulation or the hyperandrogenism, and to not use polycystic ovary morphology or raised AMH levels, because these are very common in adolescents. And again, you have to exclude other causes for these. So what's in a name? Well, a rose, even if it were called something else, would smell just as sweet. And this, as said in Juliet in William Shakespeare's play Romeo and Juliet. And the implication here by Shakespeare is that a name is nothing but a word, and it therefore represents a convention with no intrinsic meaning. If we look at attribution of disease names, well, traditionally they've been quite random. They've lacked consideration of implications for key stakeholders. And this is all diseases I'm talking about now. You can have your eponymous names, which are named after the discoverer or promoter, such as Cushing's, Asherman's, Down syndrome, or Graves' Addison's disease. And these names are useful when diagnostic tools are lacking and the etiology is unknown. You can also have names that are based on physiology, pathology, and enhanced understanding of the condition. And that's the current trend, such as diabetes insipidus is now referred to as arginine vasopressin deficiency or arginine vasopressin resistance, depending on the underlying cause. And this approach avoids many of the objections to eponymous names, including confusion as to the nature of the disease and potential inaccurate or misleading framing of the condition. Of course, we need to avoid perceived pejorative terms with negative connotations, such as Middle Eastern respiratory syndrome, monkeypox, mad cow's disease. And polycystic ovary syndrome is one condition that has been plagued by name challenges for decades, especially for women who suffer from this condition. So, history of the name PCOS, well, it all started in 1935 when 2 gynecologists from Chicago, USA, named Stein and Leventhal, published a case series of 7 women. And this was in the American Journal of Obstetrics Gynecology. And this was the first paper to describe the clinical triad of polycystic ovaries and amenorrhea and clinical hyperandrogenism being Hirschism. So these 7 women had all 3. And In the early 50s, Stein-Leventhal syndrome as a result began to be commonly used. In the late 1950s, polycystic ovarian disease and polycystic ovary syndrome first began to be used by some, and this was really through evolution rather than any formal deliberations. Various scientists and clinicians just started using this name. By the early 1970s, all three terms were being used in similar frequency. In the late 1970s, Stein-Leventhal syndrome began to decline, and in the late 80s became markedly less common, whilst polycystic ovarian disease and polycystic ovary syndrome were used interchangeably. In the early 90s, PCOS began to dominate, although today polycystic ovarian disease and Stein-Leventhal syndrome are still used infrequently. So we've always known that the term polycystic is scientifically inaccurate, but we've finally got the scientific proof of this with this paper just published in JAMA in 2026, which was a Finnish cross-sectional study comparing women with PCOS versus women without PCOS. And when you look at the number of follicles, the incidence of 20 or more follicles being between 2 and 9 millimeters in the ovary, you can see that there was a significantly higher proportion in the women with PCOS compared to the women without PCOS, which was statistically significantly different. But when the two groups were compared in terms of benign cysts, there was no difference between the two groups in simple cysts, para-ovarian cysts, hemorrhagic cysts, and also when they were compared in terms of pathological cysts, there was no difference between the two groups in terms of endometrioma and dermoid cysts. So the findings of this study provides evidence that the concern of benign or pathological ovarian cysts in PCOS is unfounded, and it supports a global process to change the condition's name. So the problem with PCOS was that it was a misleading name. It affects 170 million women globally. More than 70% remain undiagnosed. And in 2012, the NIH, National Institute of Health in the USA, recommended renaming the name, and 84% of around 7,700 women with PCOS and health professionals agreed that the name should be changed. So polycystic, as we've just heard, is a misnomer. There are no pathological cysts. Okay, they're just arrested normal antral follicles with eggs in them. And the name PCOS also had a single organ framing about it. It masks a multi-system condition, being endocrine, metabolic, reproductive, psychological, dermatological, and it also has potential for had potential for downstream harm in terms of the inaccurate name complicates funding, policy, research, guidelines, education, and health outcomes. So there have been previous attempts to change the name of PCOS, but they've stalled. So back in 2012, as I said, the National Institute of Health in the US called for a name change. And the reasons for these renaming efforts being stalled is that first of all, there was a lack of global leadership. There was no inclusive being with women with PCOS and health professionals and multidisciplinary international coordination or governance structure. It lacked patient engagement. There was a lack of an agreed alternative name. So there was no stakeholder consensus on surveying patients and health professionals on potentially scientifically accurate name replacements. And there was also a lack of implementation strategy. So no roadmap for transition in clinical research and policy systems. whereas this recent initiative addressed all these 4 barriers. So this paper that we published in the Lancet Clinical Med in 2025, so last year, this really was the paper that achieved a mandate for changing the name. And there were 7,708 participants, being both women with PCOS and health professionals, 6 continents, and it was the largest ever name consultation in terms of changing any disease in the history. And in the surveys, 85% of patients believed that abnormal cysts were a feature. Again, in the surveys, 86% of patients supported a name change. And in the surveys, 76% of health professionals also voted for a global consensus name change. And there was a workshop, the second of 2 workshops that voted for a global consensus name change. So as I said, this was the paper that achieved the mandate for change. So as a result, there was a global coalition of partners to be involved in the name change. The leads were Helena Teed, who led all this, who is at Monash University in Australia. There is Verity PCOS UK, which is a patient charity and advocacy group in the United Kingdom, and the Androgen Excess PCOS Society. There was also an international steering committee set up involving or consisting of, there were 11 of us. I think there were 2 patients and 8 or 9 multidisciplinary health professionals, including a academic. And there was the Androgen Excess PCOS Society board, which was the advisory body consisting of international academic leaders. There was funding from the Centre for Research Excellence in Women's Health and Reproductive Life, otherwise called CRE World, and this was based in Melbourne, and it was funded by the Australian National Health and Medical Research Council. In terms of collaborators, 56 organisations, and these were multidisciplinary medical societies and patient advocacy groups and their members, and it was across all world regions. And in terms of being multidisciplinary, there were obstetrician gynecologists, reproductive endocrinologists, fertility doctors, pediatrics, dermatology, primary care, psychology, nutrition or exercise, nursing or midwifery, imaging, so ultrasound and so forth, academia and laboratory work disciplines all involved. And in terms of patient organisations, they came from around the world, including Australia, UK, USA, Europe, Asia, Africa, South America, and the Middle East. So this is a list of the 56 societies. I won't go through all of them for obvious reasons, but you can see there was one Brazilian Society of Endocrinology and Metabolism. That was one of these societies that were involved in this name change process. So a multi-step rigorous global consensus process was then undertaken. First of all, governance and funding was set up, and this happened in 2024. We then had our the first survey of this process, being Survey A, which was a global Delphi survey in 2025. Then we had a workshop A in November 2025, which looked at all the results of the survey A and narrowed the process down, but not quite enough to agree. We agreed on terms, except not the reproductive term. We had to go out and resurvey people and look at marketing as well in terms of the reproductive term, and then putting the terms together. That was done in December 2025 through to January 2026. And then we had our final workshop in February this year to agree on knowing the results of that survey, to then agree on the reproductive term and then the preferred terms and then the acronym. And now there is a 3-stage transition period and implementation strategy which will be in place. So there's been an unprecedented scale of global engagement involved with this. There has been over 22,000 survey responses in total for the whole process. There's been 56 organisations involved, medical societies, multidisciplinary patient advocacy groups, which I mentioned before, in both the surveys and both the workshops. And in the workshops, there were 90 nominated representatives from those global organisations that were present at both the workshops. So the naming principles which came about from a co-design, being women with PCOS and health professionals designing the survey. And these were agreed from the survey responses. So what people wanted was scientific accuracy to reflect the polyendocrine metabolic pathophysiology and to remove the inaccurate cystic term. People wanted patient outcomes focused to facilitate diagnosis, awareness, and evidence-based care. It wanted stigma avoidance to avoid reproductive fertility or certain reproductive fertility terms in high stigma cultural context. I wanted clarity and ease of communication with the new name, so it was understandable to patients and clinicians, researchers, and the public globally. They wanted cultural appropriateness, so it was acceptable and interpretable across the diverse global regions. And they wanted implementation feasibility to enable a practical, coordinated transition in clinical care and research and policy. So the naming approach, again, this was through a co-designed survey A, and there's 3 ways of coming up with names. You can have a new name, accurate name, a generic name, or retain the current acronym and just change the individual terms in them. And what was supported overall was a new accurate name, which 82% of those surveyed supported. So this was the prioritised approach, and it was well and truly first ranked in the survey by far. So that's what the people wanted, people being women with PCOS and health professionals. And in the surveys, actually the majority of those in the surveys, about 2/3 of the participants in the surveys were women with PCOS. So this has been predominantly driven by women with PCOS, this name change process. Only 48% supported the generic name, so it was rejected because less than 50% had less than 50% support. Retaining the acronym with different terms, only 25% supported this, so again, it was also rejected. And the main concerns with retaining the PCOS acronym and using different terms were a lack of recognition of there actually being any change. So the preferred terms in the new name through the surveys and workshops end up being polyendocrine or endocrine, metabolic, and ovarian. And the polyendocrine, it reflects the multiple interacting hormonal abnormalities seen in the condition with hyperinsulinemia, hyperandrogenemia, increased LH, AMH, adipokines, and the IGF-1 signaling systems. And it captures the complex interacting hormonal disruption. It's just not a single organ like ovary disorder, as in the past term. And it was an evolutionary approach in that the similarity with P in PCOS acronyms supports a smoother transition. The term metabolic was because of metabolic dysfunction is driven by insulin resistance, which contributes to androgen excess. It's also driven by low-grade inflammation, adipokine signaling dysfunction, And these cardiometabolic complications manifest clinically as impaired glucose tolerance, type 2 diabetes, gestational diabetes, cardiovascular disease, metabolic dysfunction associated steatotic liver disease, hypertension, dyslipidemia, and vascular dysfunction. And the term ovarian indicates ovarian dysfunction, which includes endocrine dysfunction with the dysfunction in ovarian steroidogenesis with hyperandrogenism, increased AMH levels, and there's folliculogenesis disruption happening in the ovary, leading to accumulation of small antral follicles and ovulatory disturbances. And these ovarian dysfunctions manifest clinically as ovulatory dysfunction, menstrual irregularity, and infertility. And ovarian was preferred over the terms ovulatory or ovary because it was considered to be the latter two were too narrow in that they weren't inclusive of ovarian endocrine and AMH disturbance, and it also did not extend beyond the menopause. So the preferred combination in the new name was polyendocrine metabolic ovarian, okay? And in terms of coming up with this combination through the surveys and workshops, you know, it had to explore the name, the acronym, make sure there wasn't any duplication of the acronym, make sure there is not like another organization name somewhere in the world completely unrelated to healthcare that has the same acronym, PMOS and things like that. So, and also had to look at language, stigma, and cultural implications. We had marketing expertise look at this name in terms of branding and communication to assess feasibility, clarity, and transition strategies. And the evolutionary rebranding was supported in that there was some similarity to the current acronym being PCOS, and that enables smoother transition. And in the final workshop, where there were 90 participants, 98% actually supported the new name, all except for 2, and it was the same 2 actually did not support changing the name in the first place. So then this led to the publication on May 12 in the Lancet announcing the new name, all right? And it has received quite widespread media interest, including New York Times, Time Magazine, both in the USA, and The Guardian in the UK. So PCOS misrepresents, and we've already gone through a bit of that about this. No cysts in the ovary. It does not capture the multi-system disturbances, and it directed all the attention to a single organ, being ovary, for decades. Whereas the new name PMOS reflects the different genetic, endocrine, metabolic origins. It captures the multi-system disorder. It eliminates, there's no name cyst, no misleading cyst name in it, and it reduces stigma and clinical ownership. So 86% of about 4,200 women with PCOS supported the name change. 76% of about 3,500 multidisciplinary health professionals supported the new name. More than 22,000 people surveyed in the co-designed international surveys had supported this. And as I mentioned before, about 2/3 were actually patients in these surveys. And as I've mentioned before, there's been 56 pertinent leading global professional multidisciplinary medical societies and patient advocacy groups and their members were involved with this as well in taking part in the surveys and workshops, and 98% of the workshop participants agreed on the new name. So there is now a 8-stage global implementation strategy underway. The first stage is that of publication and academic dissemination. So it all started with the Lancet paper recently published, and now it's going to be supported by expert commentaries and editorials, textbook updates. There's going to be second stages that of resource development, so co-designed multilingual patient and clinical resources going to be designed. Step 3 is global communication and engagement through societal toolkits, multimedia dissemination, professional education programs. 4 is health information systems integration, so embed PMOS into electronic health records, SNOMED CT, health professionals education through university curricula and textbooks. Number 5 is policy and research alignment, so engage with governments, regulators, research funders, journals, healthcare industry, including pharma, to support the adoption process and research, classification, publication and funding processes. There will be international classification and global bodies, engagement with WHO with their ICD code integration, and that's currently underway. And there's going to be a transition and future refinement. So we expect there to be a 3-year managed transition period with monitoring and evaluation. And finally, the international guidelines on PCOS 2023 will be updated in 2028. We've already started having our guideline group meetings on this, and we'll integrate PMOS into those new guidelines in 2028. And these guidelines, the current guidelines in 2023, are already used in 195 countries. So PCOS is PMOS acknowledgements. This is all the authors of that Lancet paper, and as I mentioned before, this whole initiative was led by Professor Helena Teed at Monash University in Melbourne, Australia. And there's been a lot of social media interest in this name change. So back in January, I proposed informing people that the name is going to change. We at that stage still had to do the final workshop, so I didn't know the new name. But I announced that how there's been a lot of global multi-step process involved in this. Like it wasn't a group of 5 doctors sitting around a table somewhere considering themselves to be experts coming up with a new name. And then on the day of the publication of the Lancet paper, I also posted regarding that Lancet paper. So thank you.
Thank you, Michael. Thank you so much for your excellent presentation. It was a comprehensive overview of PMOS and the rationale behind the new nomenclature, which is quite important, and its potential impact on how we understand and manage this condition. So we have no idea about all the work that is involved in a new name for a medical condition. And it's interesting to see, like, this is you and your group making history with PMOS. So it's widely believed that adopting the term of PMOS will help shift the perception of the syndrome from predominantly reproductive disorder to a broader endocrine metabolic condition with multi-system implications. I believe that this was one of the main goals with the name changing. And I'd like to put some questions, to ask some questions. So how do you think that this new nomenclature can facilitate greater engagement among endocrinologists, nutritionists, psychologists, primary care physicians, and reproductive specialists, ultimately promoting a more integrated model of care. And also, what strategies are being used to encourage its adoption globally? You've spoken a little bit about it. And how has this process been approached in Australia? I'd like to
All
have
right,
some
so
insights from you.
few sort of mini questions there, but no, thank you for the for acknowledging the extensive process involved, and hopefully this will be a template for disease name change in the future, for for other diseases and things to follow. So the more accurate name, acknowledging that it's a multi-system disorder that we've talked about today in the slides, should promote greater awareness, first of all, against because we know patients were being not diagnosed, and if they were being diagnosed, it was delayed, the diagnosis, and previous surveys have shown they were unhappy with this and the care being provided, and everyone just focusing on the ovaries. So I think this name change, as we say, it's just one letter, but it's more than one letter, because it should promote greater awareness amongst both patients and health professionals, so that everyone's aware it's a multidisciplinary. I've had patients comment to me on my Instagram saying, oh my God, I think I might have PMOS. I never realized what that this was, that this condition had these features and things like that, and I have those features, so I'm going to go and see my doctor and get checked out, so to speak. So and through that, it should improve the diagnosis of PMOS, and also do it faster. Also, and as we said, it is a multidisciplinary. Health professionals are involved, need to be involved. Okay, it's not just a gynecological disorder, as we know. And I think that the name change has brought that to everyone's attention.
Yeah, perfect. So about impact on future research, how do you envision that the new nomenclature influencing the design of future studies, particularly regarding phenotype stratification, biomarker discovery, and the development of more personalized treatment approaches? As I said, this development of personalized treatment approaches is something that I think it's quite important for clinicians.
Well, we know it's a syndrome because it does have multiple connecting features. In terms of research, it should, now that, because in the past, and well, I'm hoping now this will change, but it's always come under gynecological or reproductive research, right? In terms of, and hence you were limited to the funding bodies down those streams, all right? Whereas now this opens up the funding streams to so many more different aspects, being cardiovascular disease and other endocrine and so forth, of all the multi-systems. So now that should, as I said, increase the number of funding streams where PMOS research can apply for, open up more avenues to get funding. With increased funding will come hopefully improvement in care, but also there will be more funding for research into the cause, the underlying cause of PMOS, which currently we do not know at the moment. So the funding hopefully should improve all of those. And yes, there are different phenotypes, and that is part of the implementation strategy now going forward, will be to help promote more research, research focus on the subtypes or phenotypes of PCOS, so that we can say that someone with, you know, subtype A is at risk of this and this, but subgroup B is not, and the treatment will be different, things like that. So, and I think this name change process will help people realize that there are these subtypes here, because there are a lot of different features in the condition.
All right, and kind of a question looking back. If PMOS had been the name from the beginning of the syndrome, how differently do you think patient care, clinical practice, and research priorities would have evolved over the years? Which is kind of looking back, but looking to the future.
All right, so not to put any blame on Stein and Leventhal, back in 1935, you know, you really have to, that was a landmark paper in itself, connecting the amenorrhea and the hirsutism and the polycystic ovaries, that, hey, this is something going on here, and with this condition. So they certainly need to be acknowledged and applauded. But I guess it's taken this evolution. It's been, as I said, there's been previous efforts to try and change the name, numerous, but it's never really gained any traction for the reasons that I explained before in that slide. And I guess the earlier that people had this greater awareness, you would expect the earlier of all, in the previous question, first two questions that I answered, would all be happening. So you would hope that, you know, we would have been a lot further down the track in terms of healthcare and looking after women with and providing care for women with this condition.
All right. Thank you so much, Michael, for your presentation, for your time with us. I hope you can join us on the 23rd of June. We will try to arrange that, but anyway, thank you for being with us today.
Thank you very much.
Bye. Bye.